morning, everyone. My name is Jenny Hoy, and I'm the Director of HIV Medicine at the Alfred Hospital and Monash University. And I've been asked today to talk a little bit about what I heard at the AIDS Conference 2022 in Montreal and also at ASHM 2022 at the Sunshine Coast, which was relevant to people with HIV over the age of 50 years. So I'd first like to acknowledge the traditional custodians of the land. For me, it's the Boonwurrung people and Wurundjeri people of the Kulin Nations. I want to pay my respect to their elders, past and present, and extend that respect to any Aboriginal and Torres Strait Islander people here today. Now, AIDS 2022 was a conference that was quite interesting. It was a conference where AIDS activism was rejuvenated. The stage was often taken over by people with HIV, and that was great to see. It was also a conference that emphasised global health inequities. It focused on stigma and discrimination. There was no Canadian government minister prepared to attend, and many delegates were unable to attend because their visa applications were denied by Canada. And it was also a conference where many Australians acquired COVID. And the other important thing happened at the end of the conference, and that was when Professor Sharon Lewin took over from Professor Adeba Karuuzzaman as IAS president. And many of you may not know, but Adeba was my clinical research fellow at Fairfield Hospital in the late 80s and early 90s. So a real Australian connection as IAS president. Now, one of the first studies I'm going to talk about was one of the co-chairs' choice. It was in a session with 4 presentations that were the selected presentations from the entire conference. And this was the DoxyPEP study. So doxycycline post-exposure prophylaxis for the prevention of sexually transmitted infections among men who have sex with men and transgender women living with HIV or on PrEP. Now, this was a randomized study. This was the cohort of people with HIV, and this was the PrEP cohort. They planned to recruit similar numbers into each group. And randomization means that by, for example, the flip of a coin, people were assigned to either no PEP, no post-exposure prophylaxis, which is the standard of care, or a 200 milligram dose of doxycycline taken within 72 hours of a condomless sex act. Twice the number of people were randomized into the doxycycline arm compared to the standard of care arm. And the endpoint of the study was the number of new, incident means new, sexually transmitted infections, either gonorrhea, chlamydia, or syphilis, that were detected every 3 months, every quarter. And this study showed that doxycycline was effective, so much so that the Data Safety Monitoring Board, and that's a group of people that review the results of the study in an unblinded fashion. In other words, the investigators and everybody else probably weren't aware of the results of the study, but the Data Safety Monitoring Board did. And they said, no, we've got to stop recruitment because the outcome of the study, doxycycline does reduce sexually transmitted infections. So this is the baseline characteristic. So that means of the people recruited what were their characteristics at entry into the study. And you can see that 327 people were recruited into the PrEP group and 174 in the people with HIV group. Now, remember, they were going to recruit 390 into each group, but they only got to this number before the Data Safety Monitoring Board said, don't recruit anyone else. You can see that the median age of those living with HIV was higher than the PrEP group, that 2/3 were white. This study was done in the US. That, of course, we were recruiting men who have sex with men and transgender women. So 98% were men. 86 to 88% had male sexual partners only. And you can see that the sorts of sexually transmitted infections, which was a criteria for entry into the study, that gonorrhea and chlamydia were the most common. The median number of sexual partners in the prior 3 months was 9 in each group, and substance use in the prior 3 months was about 55 to 70%. Now, first of all, there was no clinical or laboratory adverse effects that were significant observed in the study. It was well tolerated, the doxycycline, and only 1.5% of people discontinued doxycycline during the study. There was a median of about 7 sex acts per month reported, and almost 90% of those acts were covered by the DoxyPEP in those that were randomized to receive it. And you can see that half took less than 10 doses per month, 30% took 10 to 20, and 16% took over 20 doses of the doxycycline per month. You could only take 1 dose in 24 hours. And these are the results. This is the PrEP cohort on the left, the DoxyPEP group, and the standard of care group. And you can see that there were 257 in the standard of care group and 570 in the DoxyPEP group. So that shows you that the randomization, 2 people to DoxyPEP, 1 person to the standard of care, was the same. You can see exactly the same in the people with HIV. Now, this blue here is those with gonorrhea. The red is chlamydia, the green is syphilis, and the purple is 2 or more sexually transmitted infections. And this is per 3-month visit. You can see that gonorrhea did decrease, but not as much as chlamydia and syphilis and 2 or more infections. And the same applied to the people with HIV. The gonorrhea did decrease, but not as much as the other sexually transmitted infections. But there was, in the PrEP group, a 66% reduction in opportunistic infections, and for people with HIV, it was 62%. Now, this is in comparison to a study that was done in France that was reported about 4 years ago. This was done by Jean-Michel Molina. And again, it was doxycycline taken after condomless sex to prevent a sexually transmitted infection, with similar reductions in chlamydia and in syphilis. But it was not effective for gonorrhea in France. It does appear to be effective for gonorrhea in the US. Now, why is that? And it's possibly due to the fact that there's only 20% resistance in gonorrhea to the doxycycline. Doxycycline is a tetracycline antibiotic, whereas in France, 56% of their gonorrhea is resistant to the doxycycline. So when an organism, when a bacteria is resistant to an antibiotic, the antibiotic isn't going to be able to work. This is from this study, the DoxyPEP study, and the green are those isolates that were susceptible to the doxycycline, and this is at baseline. If you look during the study, even in the standard of care arm, there was no cases of gonorrhea detected that was susceptible to the doxycycline. But you can see that the intermediate resistance and the total resistance was there, and there was perhaps more resistance proportionally in the DoxyPEP arm. So the conclusions of the investigators were that DoxyPEP, doxycycline, taken within 72 hours of condomless sex does reduce new sexually transmitted infections, and it was reduced by 62% in those with HIV and 66% in those with PrEP, and new gonorrhea, chlamydia, and syphilis were all reduced. They suggested that this would provide prevention against sexually transmitted infections in populations where there's a high rate of STIs. But the downside, and this is why many people are not embracing doxycycline, is that gonorrhea acquires resistance to antibiotics very easily because of the way the bacteria is created, I guess. It has mechanisms whereby it can acquire resistance to other antibiotics that are just around in the system. And also, we don't want other bacteria, such as Staph aureus, which is a very important bacterial infection, to develop resistance to doxycycline if it's being used widespread. And we don't know what the impact of tetracycline or doxycycline will be on the gut microbiome. The gut microbiome is the bacteria in the gut that has an impact on our immune system, on inflammation, on many things. So although this works, and it probably is appropriate for people that have a lot of condomless sex, there is concern about the downstream effects. There was another patient who was found to have been cured of HIV. It was the City of Hope patient, a 66-year-old man, so an older individual who had acute myeloid leukemia. And as part of the treatment for that, he had a bone marrow stem cell transplant that was missing that important CCR5 surface marker, which is important for access to the cell by HIV. He continued his antiretroviral therapy for 2 years, but he had continued his antiretroviral therapy for 2 years after the transplant. Then he stopped his treatment, and 17 months later, there's still no evidence of HIV DNA in his body. So that is the 5th person who has been cured of HIV following a transplant. And there was also a presentation of a functional cure. Now, functional cure is where people can maintain an undetectable viral load without antiretroviral therapy. So this is like an elite controller. And in this woman, she has been undetectable for 15 years without antiretroviral therapy. And it's unclear whether she's an elite controller or a post-treatment controller, but somebody who I'm sure her blood and her tissues will be intensely researched to try to understand how this is achieved and how we might be able to do that for more people. This is the Aging with Grace Symposium, and Jacqueline Capot presented some metabolic consequences of new classes of antiretroviral therapy. And on this symposium was really a basic science symposium, but there were some things that I thought you might find interesting. The first is the changes in fat in the body with different antiretroviral drugs. And I'm sure many of you will remember the lipoatrophy due to zidovudine and stavudine and DEI. And then the phase where there was fat accumulation in the abdomen called truncal fat accumulation, which has been blamed on the protease inhibitors. And more recently, there's been a lot of talk about integrase inhibitors and tenofovir alafenamide causing weight gain. And that weight gain is different because it's global. It's both subcutaneous and truncal fat. Now, truncal fat accumulates in people with HIV with aging, but it also happens in people without HIV with aging. So the body mass index is your weight over your height, your waist circumference, which is how much fat is in your abdomen, and your waist to hip ratio all increase with age. So that's trunk fat accumulation. And there's been some work done looking at risk factors for weight change in people with HIV. And the weight gain is in the red arrows and weight loss in the blue arrows. And if we just look at starting antiretroviral therapy, the return to health, HIV and chronic HIV multiplication causes weight loss. And so some of the weight gain when starting antiretroviral therapy is due to return to health. This is more pronounced in people with more advanced HIV, so those with much lower CD4 cells when they start ART, and those with a higher viral load, and those with a lower weight when they start antiretroviral therapy. We do know that the integrase inhibitors and tenofovir alafenamide are associated with weight gain through mechanisms that we still don't understand. But we also know that the different formulation of tenofovir, the disoproxyl fumarate one, that was the only form of tenofovir available to us, and also efavirenz, both cause weight loss. And this might be because of weight appetite suppressant. And then we know that women are more likely to gain weight, people of Black race are more likely to gain weight, people aging gain weight. If you've got the bad genes for gaining weight, there's often family genetics, and also bad diet. But physical exercise, good genes and good diet are associated with weight loss. So in the end of her talk, she talked about the integrase inhibitors and TAF being associated with global fat gain, not just truncal fat, but subcutaneous. And most of that fat gain occurs during the first year of treatment. but that only a minority of people have marked fat gain. In fact, it's probably less than 5%. Gaining weight can also occur if you stop smoking. So many people, when they're diagnosed with HIV, decide they're going to start look after themselves. They're going to stop smoking. They're going to change their lifestyle. But we also know that using steroids, that some antipsychotics or some medication for depression, severe depression, causes weight gain. And of course, we all know after 2 to 3 years of lockdown that most of us gain weight being stuck inside. But what are the consequences? At the moment, there seems to be minimal indication of increased risk of heart attack. There's no indication of an increased risk of diabetes, and there is an improvement in the lipids if you use the integrase inhibitors. And finally, the reversibility of that weight gain still remains uncertain, even 3-4 years after we first noticed it. Now, there were some posters that looked at the effect of aging on antiretroviral treatment effectiveness. This is data from the Tango and Salsa studies. So this is switching to the 2-drug regimen dolutegravir 3TC and looking at those greater than 50 versus those less than 50. And in fact, 30% of people in these studies were over the age of 50. And what the conclusions are that there was no difference in efficacy, no difference in change in CD4 cell count for those that switched to the 2-drug regimen compared to those that continued on their current antiretroviral regimen of 3 or more drugs. The weight gain was greater in those that switched to dolutegravir 3TC, and that's because there were higher rates of people that were on those appetite suppressant regimens of tenofovir, disoproxil fumarate, and efavirenz. So removing that appetite suppressant meant that people gained weight. What about long-acting cabotegravir and rilpivirine that's available now for us to use in Australia? Is there any difference for those less than 50 versus those that were greater than 50? And in this study, there are over 200 people that were over the age of 50. I just want you to note that for some reason, there were greater comorbidities in those that were over 50 on the long-acting arm of the study. But when you compared with the less than 50 group, both on long-acting, 40% of people had 3 or more comorbidities, the purple, compared to 18% in those less than 50. And the same with co-medications. Those greater than 50 were taking 3 or more co-medications other than HIV medications compared to 17% in those that were less than 50. There was no difference in virological outcomes in any group for those less than 50 versus greater than 50. You can see that they're the same, no statistically significant difference. If we look at treatment satisfaction for those that were less than 50, there were more people that were happier switching to long-acting antiretroviral therapy compared to those staying on their oral regimen. Interestingly, for those greater than 50, both groups had a better treatment satisfaction, and there was no difference between the long-acting group versus the continued oral therapy group. Just a little bit curious, there was a very low rate of treatment failure, and it was no different between those above 50 and less than 50, and it was rare at 1 to 2%. The safety and the tolerability was the same. So irrespective of age, long-acting cabotegravir and rilpivirine is a treatment option for those who are older. And the final thing I wanted to bring your attention to is there were a couple of studies looking at alternative self-administration, because at the moment, to get long-acting injectable cabotegravir and rilpivirine, you have to go to your healthcare provider, to the clinic, to have 2 separate injections administered by a nurse or a doctor every 8 weeks. And compare that with 1 or 2 daily pills and going to the clinic every 6 months. For some people, the 1 to 2 pills is easier than attending a clinic every 8 weeks. But for those that would really prefer long-acting injectables, there've been 2 studies. One study was looking at injecting into the outer thigh, and the concentrations of the antiretrovirals were well above the active levels and were within the range seen with the buttock injections, but of course those injection site reactions remained very common in the thigh. And a second study looked at a higher concentration of the formulation of cabotegravir, and it was double the concentration, and it was given either intramuscularly in the buttock, intramuscularly in the thigh, or subcutaneously under the skin. And what they found was it was absorbed faster, but it would have to be given every 4 weeks, and a higher volume was felt to be impractical for individuals, because at the moment the volume is 3 mils for each of the cabotegravir and rilpivirine. And finally, there was some data from Australia on quality of life for people that were older. And this study looked to describe the quality of life people aged 50 and over, and 2/3 of the people that completed the POSQUAL indicated a good quality of life. The good quality of life was higher among participants in a regular relationship, and it was lower among people who had poorer social determinants of health. In other words, those that had financial stress, ran out of food in the previous 12 months, were depressed or experiencing stigma related to HIV. So even though quality of life among people with HIV was reasonably good, it was really strongly associated with accessibility of social services and personal stresses. Now I'm going to move to the ASHM conference, where we had Joel Palevsky presenting the anchor study. And the anchor study was actually presented at CROI earlier this year in 2022, but Joel was one of the visiting people at ASHM, and there was a symposium at ASHM, and then Joel came to Melbourne, and we held another symposium at the Alfred Hospital to talk about the results of the study and implications for Australia and for Melbourne, which is slightly different to Sydney. So just as a bit of background, this is the incidence per 100,000 person years of anal cancer. This is men, this is women. This is men who have sex with men. This is non-men who have sex with men. And this is people with HIV who are male, who have sex with men, compared to people HIV negative men. And then this is age, greater than 50, 45 to 50, 30, or 20 to 44. So the highest risk of anal cancer occurs in people with HIV aged greater than 50. So the anchor study was a randomized study that was set up to determine whether treating high-grade squamous intraepithelial lesions in the anorectal area, in the anal area, to determine whether treating them is effective in reducing new anal cancer in people with HIV. Now, HSIL is also anal intraepithelial neoplasia. It's the same thing. AIN 2 and 3 equals HSIL. This study was also set up to determine the safety of treatment for high-grade squamous intraepithelial lesions, which are the precursors of anal cancer. In other words, these lesions can progress to anal cancer. So this study was only in people with HIV over the age of 35. It was for men and women. They were screened for anal HSIL, and screening meant an anal swab for human papillomavirus. And human papillomavirus is the virus that causes anal cancer and cervical cancer. And then everybody underwent a high-resolution anoscopy and biopsy of any suspicious lesions. And it was only those that had this high-grade squamous lesion that were recruited to the study. If there was no lesions found, people weren't enrolled. If cancer was found, they exited the study and had the appropriate treatment. And so people were enrolled, then they were randomized by the computer or the coin into either active monitoring, which is what we do in Melbourne, or the treatment arm. And then people were followed every 3 to 6 months. And if cancer was found, they exited the study and had treatment for the cancer. If no cancer was found, they stayed in that active monitoring arm, the same with the treatment arm. And there were very tight guidelines for the treatment. And so the majority of people actually had what is called electrocautery or infrared coagulation, which is like burning of the lesion. It was done in the clinic or in the doctor's office in the US. They then returned 8 weeks later if they had that. If there was any more lesion left, it was treated, and then they were seen 3 months later. This study recruited 4,500 people through the United States, and it took from 2014 to 2021 to recruit all those people. Of all the men recruited who were, and everybody had HIV, just over half of the men had this high-grade lesion, and almost half of the women had an anal high-grade lesion, not a cervical lesion, an anal lesion. And at baseline, in other words, at entry to the study, anal cancer was diagnosed in 17 people, which was 0.2%. The average age was 54 years, 80% were male. And there was a reasonable spread of race and ethnicity. The follow-up time was about 2 years. About half the people had had advanced HIV at any point in time, and at recruitment, the overwhelming majority were suppressed. So the main results, 30 people progressed to cancer. That's 30 of the 4,500 people recruited. In the monitoring arm, was 21 people. In the treatment arm, 9 people. So this adds up to a 57% or 60% reduction in anal cancer over 2 years. And this was the incidence of cancer. There was 402 per 100,000 person years compared to the treatment arm of 173. And this is the graph that was in the paper in the New England Journal of Medicine. And because this was so small down here, this is 100% risk of anal cancer. And after 48 months, it's still less than 2%. They had to expand it. They had to enlarge the graph to show the difference between the active monitoring arm, that is, these are all of the cancers that developed over time. Each circle is a new cancer compared to the treatment arm. Treatment of high-grade lesions is effective in reducing progression to anal cancer. But having said that, there's still room for improvement in the treatment arm. There were still 9 people who developed cancer. So we need to improve how we screen and recommend follow-up and treatment of high-grade lesions. And for Australia, that means a large scale up of high-resolution anoscopy training programs. And really, there's no availability of anoscopy and treatment in clinics in Melbourne. There is small availability in Perth and slightly in Brisbane and more so in Sydney. So for us, that means we really should be concentrating on digital anorectal examination in everyone over the age of 45 years with people with HIV. Now, at the same session, the SPANK study was presented by Andrew Grulich. Now, the SPANK study was done in Sydney. It was conducted over 8 years. It recruited 600-odd gay and bisexual men. None had had prior high-resolution anoscopy or were aged greater than 35, and they all underwent exactly the same screening as for the ANCHOR study. 2/3 of the 600 were HIV negative, and 1/3 of the group had HIV. Median age 50, very similar to ANCHOR. 2% had been vaccinated against human papillomavirus at baseline, and about 20% were lost to follow up at the first visit. The high grade, the prevalence, in other words, the rate of high grade lesions was 47% in people with HIV, and it was 53% at baseline in the ANCHOR study. So very similar between the two groups. New lesions that were high grade squamous intraepithelial lesions occurred in 11 per 100 person years, and that was more common in those that were younger, that had the people who'd had prior lesions, and those with persistent high risk human papillomavirus infection. But the other thing was that there was clearance. In other words, the lesions, those high-grade lesions can either progress to cancer or they can clear, and that was reasonably common at 22 per 100 person years. Again, clearance was more likely in those who were younger, those that had a lower grade lesion, in other words, an AIN2, smaller lesions, and no persistent high-risk human papillomavirus infection. There was only one progression to cancer in the SPANK study, and that was very similar to the rate in the ANCHOR study. So Andrew Grulich suggested that we should be doing human papillomavirus testing rather than HRA as a screening test for anal cancer. Now, for women, HPV testing, human papillomavirus testing, has replaced pap smears. You now do this test, and if you have a high-risk human papillomavirus infection, you then go on to have a pap smear that will show whether you've got any cancerous change or precancerous change in the cervix. So what Andrew's suggesting is that maybe we should be looking at anal human papillomavirus screening, and those that have the high risk subtypes of human papillomavirus, and HPV 16 stands out, it has the highest cancer risk, as HPV 18 does have a high risk, but HPV 16 rarely clears, whereas HPV 18 does clear in people with HIV, is what they found. We also know that clearance is less common with those who've had a very low CD4 cell count. We need to screen. We need to find a simple screening test that's easily implemented in primary care that maximizes detection of the higher risk lesions that progress to cancer. And we need to not overwhelm our health systems with the number of high resolution anoscopies required. This was then followed by a talk by Jason Ong. And Jason talked about primary, secondary, and tertiary prevention of anal cancer, with primary being the vaccination against HPV. All of our young boys are being vaccinated against human papillomavirus infection now. The secondary prevention is treating the precursors to cancer. In other words, the treatment of those precursor lesions with electrocautery. And the tertiary is not really prevention of anal cancer, it's early cancer detection. And that's what the digital anal rectal examination does. So we know that treatment works, it reduces progression to cancer. So in the active arm of the anchor study, there were 21 cancers, there were 9 in the treatment arm. So you reduce the incidence of cancer by 57%. Jason worked out you would need to treat 5,000 people to prevent 12 cancers over 2 years. That's a lot of people to treat to prevent that number of cancers. Active treatment is acceptable. High resolution anoscopy, it takes 30 minutes. There's no sedation. It's repeated every 3 to 6 months. For most people, it's embarrassing and it's uncomfortable, and many people do not consider it a benign procedure. And this study came out of the US, acceptability of high resolution anoscopy. They looked at 1,860 people, 5% poorly tolerated the procedure, and of nearly 1,000 needing follow-up, half didn't return. And that tells you that, oh, that was uncomfortable and it was embarrassing and I really didn't want to come back. Bleeding occurred in almost 70%, unacceptable pain in 8%, and 25% had some discomfort for 2 to 3 days after the procedure. What about feasibility? Do we have the workforce? There are 30% of people in Australia, 30% of people living with HIV is 8,727, 70% are gay and bisexual men, 30% have this high risk anal cancer infection detected. So that means 2,260 men who have sex with men with HIV or need at least one high-resolution anoscopy per year. The current national capacity is 750 to 1,000. So again, we don't have the workforce. So what can we do in the meantime? We have to do DARE because it's acceptable and cost-effective. Primary prevention is probably too late for many people living with HIV. Secondary prevention is possible, but we have limited resources to do that. And the final thing that was presented by Dean Cassano was aging well with HIV. This was from the Future study where people over the age of 50 self-reported data. There were 319 people, median age 59, mostly male. 43% reported being diagnosed with a mental health condition. Support friends were the most common source of support. 1 in 4 people said they didn't have anybody to ask for support if they were ill. 1 in 5 said they didn't have anybody to talk to if they were feeling down or depressed. 1 in 3 said they asked for support or advice from someone else living with HIV. 2/3 said they had at least one conversation with one other person with HIV, but almost 1 in 4 felt isolated or cut off from other people with HIV. Half had experienced some form of discrimination in the last 12 months, and half said they did not want to have, others said they did not want to have sex with them because of their HIV status. And over half reported that most of the time people weren't aware of their status or that almost nobody knows about their status. The future concerns, 60%, 50% and above, other illnesses, other comorbidities, aging, HIV-friendly services, finance, independence, illness from HIV and pain. No one would be there for them. Dementia, the need for emotional support. Really concerning and things that we need to do something about. So where do we go from here? We need programs that specifically support older people with HIV. We need to advocate for their needs. And we need smarter ways of extending our current services because resources are a problem. And the Well Beyond 50 resource that I know many of you are aware of. Biological age or your phenotypical age can be impacted. I mean, obviously, your age is your age. You know how long you've been alive for, but your functional, phenotypic, biological, that's all impacted by many things. That includes something that you started to talk about, which is immunosenescence. And immunosenescence is a cellular process whereby some of the DNA has telomeres, and telomeres shorten over time as we age. And that shortening can be accelerated by other things. And we went through a stage where we thought some of our antiretrovirals might accelerate the shortening of telomeres and so accelerate aging. But I think that that was perhaps a little bit simplistic, and I think it's hard because I think that people are now describing many processes that have an effect on senescence of cells. And what senescence of cells is about the ability of cells to multiply or replicate. And when they're senescent, they can't. And different cells will be impacted at different rates by the processes. So we know that one of the presentations in the Aging with Grace symposium at the AIDS 2022 talked about cytomegalovirus. And cytomegalovirus is a very common viral infection in people with HIV. About 60% of the general population aged greater than 40 have been infected with cytomegalovirus. It's commonly spread at playgroup in young kids under the age of 5. It's in saliva. They share their saliva, they kiss each other, etc. And they get an asymptomatic infection, but that infection never clears. And so once you've had CMV, you have it for life. And as you age, more and more of your immune system becomes devoted to controlling multiplication of cells with CMV in it. In other words, the CMV specific immune response becomes predominantly against CMV. And with that, you get some more immunosenescence. It's not an easy process to explain, but there are a lot of different impacts from different parts of chronic inflammation and chronic immune activation that can cause immunosenescence and other infections as well. The other thing is that the other expression of aging and immunosenescence and phenotypic age and biological age is when two people exactly the same, say biological age, but one is able to run a marathon and the other person, the same biological age, is frail and has difficulty walking and is at risk of falls. So there's genetics that will impact, there's so many things that will impact the different responses with aging. You know, good diet, which is tough for people who have that financial stress, because a good diet is more expensive than a bad diet. And a good diet possibly takes more time to prepare than a bad diet. But there's also things like what I'm doing to try to prevent frailty, I guess, is, you know, exercise, doing Pilates, increasing your core strength. There are those sorts of things as well. Also quitting smoking, reducing alcohol intake, reducing, you know, recreational drug use. All of these things can have an impact. Cabotegravir is a cousin of dolutegravir, but having said that, cabotegravir has not been associated with significant weight gain. But if we pull back a bit and we look at where cabotegravir is being used, it's used as in people who are already virologically suppressed. We know that weight gain is always greater in people who are starting at antiretrovirals rather than switching antiretrovirals. So switching to long-acting cabotegravir and rilpivirine is unlikely to be associated with weight gain because it's already happened. But having said that, I don't know that it's going to be associated with weight loss. I think there is a couple of studies using semaglutide, which will reduce truncal fat while you're taking it. But unfortunately, when you stop taking it, that truncal fat can return, so that we need to look at other ways of maintaining the loss of the truncal fat. But semaglutide is used in diabetes, and it was an off-target effect that people didn't realize might happen. And so there are a lot of people using semaglutide now. I don't know the entire, I don't think we know that it's safe in people with HIV as yet, but there are people with HIV using it. Lenacapavir is in front of the FDA at the moment. In fact, I think it might even be in front of the TGA. So that might be available soon. Lenacapavir is a new drug. It's the drug that you give subcutaneously. You can either use it weekly, monthly, or 6 monthly. It's a subcutaneous injection, but it targets a different part of the HIV virus life cycle. So it may have different adverse effects. Nothing in particular came up in the studies that have been done to date, but only small numbers of patients in those studies. The HIV neurologists will tell us that there is an increase in HIV cognitive impairment, but that increase is in the very sophisticated testing that's done. And most people where that increase is found, it's the asymptomatic neurocognitive impairment. We're not seeing an increase in HIV dementia at all. And I think for people with HIV who are virologically suppressed, if they develop neurocognitive impairment, it is more likely due to cerebrovascular disease, in other words, atherosclerosis of the vessels that feed the brain, narrowing of those vessels that when those vessels are narrowed cause heart attacks. You can get strokes, you can get mini strokes, but you can also get this vascular dementia. And the other one, of course, is Alzheimer's. So we look very closely and rule out HIV as a cause of the dementia in aging people with HIV. But today, in 2022, the most likely cause is Alzheimer's or vascular dementia, rarely caused by HIV, rarely.